So the session is really about meeting the International Foundation for Integrated Care, giving a bit of an understanding of what we're seeking to do both now and in the future, and really hearing from you two things: how you want to get involved with us, but also what are the sorts of priorities and things that we could do as a foundation where it begins to meet your objectives and your needs. So we're very much in listening mode. We'll go around the table in a minute. I think we should all introduce ourselves quickly, because it's a small enough group and we've got time. And then we will, after talking about it generally, we can begin talking about Asia Pacific more directly, because I imagine most people here are potentially Asia Pacific colleagues, but maybe not. So let's go, I'll go right to left, so we'll probably introduce ourselves first. So you know me, so Tony.
Tony Dodell, I'm the Director of Programs of IFIC.
Anne Hendry, I'm the lead for IFIC Scotland.
Hello everyone, I'm Sarah Derrett, I'm Professor of Health Policy and Systems at the University of Otago in New Zealand.
Great.
Yvonne Zirinsky, I'm from Macquarie University and the Australian Institute for Health Innovation. I'm the Associate Professor for Health Systems Sustainability.
Fantastic.
Philip Hoyle, Medical Director of Royal North Shore Hospital, Sydney, a teaching hospital.
Helen Murdoch, Chief Executive with the Hanover Housing Association based in Scotland, and we provide housing care and support for older people all around the country.
I'm Swan. I'm a PhD student in Health Systems Research at the School of Public Health at the National University of Singapore.
Hi, I'm Elaine. I'm from the National University of Singapore, Public Health. I'm a research associate.
I'm Katrina Bagley. I'm pre-admission coordinator of the Brain Injury and Stroke Programme in the National Rehabilitation Hospital in Dublin.
And I'm her colleague, Rachel McGlade. I'm the Brain Injury Liaison Coordinator in the same National Rehabilitation Hospital in Dublin, Ireland.
Ian Clements, primarily a general practitioner, but I chair the Health and Social Care Board, which is the commissioning board for all services, both health and social care in Northern Ireland.
We were at school together.
Small world.
Where you were talking about integrated care, clearly.
And I'm deaf, by the way, so I'd appreciate it if you could shout at me. I'm Harry Ray, Irish, but been in Auckland, New Zealand for 40 years. And I'm an academic physician by profession, but I've spent the last 10 years trying to keep people out of hospital because I became so frustrated with all the people who I thought I'd done a great job with coming back 3 months later.
Yeah.
I'm David Perkins. I'm a board member of IFIC and a director of IFIC Australia. And my day job is that I'm Professor of Rural Health Research at the University of Newcastle, and I'm the director of a thing called the Centre for Rural and Remote Mental Health, based in Orange.
Hi, my name is Frances Garofoni and I'm employed by the University of Sydney. I actually work at one of the university departments of rural health in Australia, and I'm an academic and a very passionate educator and teacher, and I live and breathe integrated care in every conversation I have with students, with academics, with clinicians. Very passionate about education and training.
Yeah.
Chris Hamilton, I work at the Department of Health in Victoria, Australia.
Nice to meet you.
Rob Miller from the University of Birmingham.
I'm from the University of Tübingen in Germany, general practice and responsible for new care structures.
Okay.
Tim Smythe, the hat I'm wearing is chair of the Western New South Wales Primary Health Network in Australia, and that's a rural and remote area, and we support general practice and primary care. But I was formerly Deputy Director General of the New South Wales Department of Health and have run hospitals and health services before that, so health has been in my blood for a long time.
I'm the Director of Integrated Care at the Mater Hospital in Brisbane and Centre for Health System Reform and Innovation at the University of Queensland.
Hi, I'm Andrew Terrace with IFIC. I head the Solutions Group, which is around the implementation support for integrated care.
Hi, I'm Cynthia De Guara. I'm from Malta, working in social care standard operation. And my unit, I just deal with legal and license units.
Hi everyone, I'm Tessa Boyd-Kane from Health Justice Australia, which is a fairly new national charity in Australia integrating lawyers into healthcare teams, so public sector or community lawyers into healthcare teams.
I've just learned something. I didn't know it existed.
I'm Andrew Knight, I'm a GP. I'm the chair of a primary health network like him in the Peen Blue Mountains, which is in the western part of Sydney. But I'm also the acting director of an academic primary and integrated care unit in southwestern Sydney.
My name is Albert Alonso. I am senior researcher at the Directorate for Research and Innovation Hospital Clinic in Barcelona. I'm also a chairperson for IFIC.
Great. So, so let me spend 5-10 minutes or so just telling you a little bit about the foundation and who we are, how we operate, and so on. The foundation, interesting history, but it was founded in its current status in 2011, and it's a Dutch foundation. So we have our seat registered in the Netherlands, and our main birthplace was indeed Utrecht, and that's where our main centre is. So what is a Dutch foundation? A Dutch foundation legally it's a legal person. So we have a board led by Albert as chair, and David is a board member. Any other board members here? No? Me? Oh, me.
Oh, you.
But it's as a legal person, the board is more like the custodian of the foundation. So the foundation exists to fulfil the terms of its statutes, and the statutes really talk about the foundation being a public benefit organisation. So we're here to advance the science, knowledge and adoption of integrated care in policy and practice around the world. And the statutes say, well, how do we do this? We bring people together to share ideas, we run conferences, we have education and training programs, we do research, we support knowledge sharing, and so on. We might say a little bit more about those different activities. So all of the activity that we do at the foundation is geared to supporting the participants, the beneficiaries of the foundation, so who we're looking for. So in other words, you and everyone else who's here at the conference. So the foundation has a board which is interesting because we're going through a slight transition phase, looking for new board members from different parts of the world, but our aspiration is to have a board that's kind of very active with us to take us into the future, and a board that is representative of our beneficiaries and participants. So in other words, from different geographies around the world.
Correct, yeah.
So not just European, but Australian, Asia Pacific, North, Latin America. In the future, who knows? Africa, India.
Yeah.
We'll see. As it grows, we have maybe 7 or 8 participants from Africa here, so that'll grow. Maybe next time we'll have 20 and 30. These things will grow. But we also want to have representation of the beneficiaries, because the participants or beneficiaries of the organisation, it's really very broad. So the overall vision that we've been developing is that we really want to support, optimise, if you like, health and well-being for all people, particularly those who are most vulnerable, right? And we want to be able to do that through the lens of integrated health and care support in its broadest sense. And therefore we have a set of values that we ascribe to integrated care, and probably those of you who might have gone to the Nick Zonfeld session on values might identify quite a number of those. So holistic, developed in co-production with communities, well coordinated, all the sorts of things you might expect integrated care to represent. But what you learn from that, of course, we're not just talking about care pathways or acute, managing acute demand in a hospital sector through better intermediate care, although that's very important. It's a much wider concept, and as we've grown, we've recognised we've moved away from a paradigm that's focusing primarily on case management for elderly people in the community, or chronic disease management, which is kind of where it started, thinking much more around how integrated care as a discipline can support better health and well-being for people and communities. Very much what David was saying in the title of the conference we're going to have in Melbourne next November. So the foundation has its directors, but they all work for free. There's no, all of the profits and the surplus, such as we can find it, goes back into the business to support the activities that we undertake. And then working for the board through me as the chief executive is the team. So what does the team look like? We have basically below me we have Tony as the director of programs. Recently come, thank you Tony.
Yeah,
so say a little bit more about it.
Yeah.
But Tony's role, forgive me if I get this wrong, so we have a director of programs. So these are all like the business lines, all of the activities that we're seeking to do at the moment. And this is where you can start to give us advice as to which activities you might want to get involved in, or other things that we should be doing, etc. So we have the journal, and it has the co-editors in chief with Robin and me and Victoria Stein, who is here, and we have a managing editor of that. And that was our principal product, developed in 2000. And it's incredibly successful. So today we have something like almost 400,000, 360,000 individual visitors every year. And we get something like an article submitted for review to our journal every other working day, which is quite a lot for us to deal with, Robin. But we had a meeting about it yesterday, and we kind of said we're okay about this. So this is really successful. It's got impact rated open access. So this was our principal product. So we're very proud of that, and it's continuing to grow followership. And in fact, for those of you from Australia who are here, since we created the Collaborating Centre, actually the Australian contributors are the highest percentage. It's about 1/5 of the articles that came in last year. Admittedly from a couple of people, but nonetheless a lot of articles have come in. But that's really good, because it demonstrates that if you begin to expand the network and the ideas to other areas, then you can immediately see the interest in generating knowledge and sharing. So as a journal, we have a research and development, a small faculty. So we have 5 or 6 projects that are ongoing. Some of them are to do with EU-funded research. We do quite a lot of that, which is good job with Dutch, not British. So, but nonetheless, we do that, and we also take on smaller commissions with the likes of the Inter-American Development Bank or the World Health Organization, and other foundations and so on. In the future, as we grow, and if we do get a surplus, we'd love to fund interesting research, but that's probably sometime in the distance. So we were built. We were not built with any. How would you say? There was no seed money that started the foundation. It started completely from scratch. And as we built it up out of effort-related activities. And what really stimulated it was a first EU project that we gained, which Albert was involved in as a partner. I'm looking else if anyone else was a partner here too. And off the back of that, we started to be able to grow things back in 2011, 2012. So the research faculty is led by our head Leo Lewis, who you'd have seen in the conference. And we have 5 or 6 ongoing programs, and we're seeking to continue to have a portfolio of longer term projects, all related to integrated care, as well as smaller term projects. And our USP there as a foundation is both in terms of methodologies that we can support in terms of the design of the research programs, often about the translational aspect of it. So how do we translate this research into usable material that can be transferred across to policy and practice? But primarily, I think the dissemination, exploitation of results. And what's interesting about this conference is you're getting all of these different EU projects. You've seen it, Scirocco, Act at Scale, the Advantage. They're coming because this conference is an outlet for them that doesn't really exist anywhere else. And it's really tremendous to see just how much they're coming. And the European Commission, also, who fund a lot of this, coming to actually do sessions with us. So we do have the research faculty. We also have an education and training arm through the Integrated Care Academy, That's led by Victoria Stein, currently on sabbatical, so we're hoping to make sure she comes back. And that has a range of portfolio activities, from developing with supporting master's courses such as in Scotland and other parts of the world, in Netherlands and elsewhere, developing our own short and long-term courses, often geared at students, but also at professionals and managers as well, to refresh their skills and knowledge in the sector. I think some of the most popular ones actually are the kind of week-long residential courses, summer schools or accelerated learning programs, and David might talk about when we come onto the hubs around what we're doing in Australia, because it's proving to be really popular to bring groups of individuals who are developing integrated care programs together for a week and take them on a journey from their initial ideas through to a plan in a kind of an accelerated learning program. So those sorts of activities. And we have study tours and learning sets, all sorts of things. And then we have solutions, and Andrew might say a few things about that, but that's a growing area for us. And it's not that we have a huge faculty of people. I think we have 12 to 13 whole-time equivalent people working for the foundation directly. The value of what we represent is in the network who are part of what we do. So when someone comes to us and says, for example, we're interested in building a long-term care hospital in Salvador, Brazil, I start scratching my head, and then I think, oh, well, I know who's going to be really important in that, and it's our friends in Scotland and our friends in Catalonia. So I kind of sent out a few emails, and they said, yes, we can do it. And actually, it proved to be a very successful project, and we've had significant follow-up with Brazil. And following that follow-up, we're now thinking of creating collaborative centres, and the thing grows and grows. So we're using the expertise across our network to find solutions for other people within the network. So you can see how the operational aspect of it. So we're not a consultancy firm doing things with people, we're networking people together to find the right sort of bespoke group that can help people take things forward. And I think that's a very valuable way of thinking and working. And we've got really interesting big project in Estonia, which is one of the flagship projects that Andrew might talk about. But increasingly, I think over the next, well, the other thing we've decided is we've got away from having memberships. So everything's free and open access. So anybody who registers with the site is one of our participants. It's very easy to join the fold. We want you to be able to have no barriers to come to be able to get engaged in our activities. I think that's very important. But as we grow, next few years, we want to be able to create more of a knowledge observatory, that's one of your phrase, knowledge business, if you like. And we already have some very significant movements, led by Scotland, I would say, with the webinar programs, which have been really very interesting, and you can access those for free and watch those, because you get some very high quality conversations and presentations through those. And we did about half a dozen in Australia last year for the Asia Pacific, so we're going to continue that. So give us your ideas. Who would you want to listen to? What do you want to learn? What sorts of engagement would be helpful? The special interest groups, many of them have come to the conference here. So if you want to, there are areas that you're bursting to find out what's going on elsewhere in the world, come to us, and we might be able to find ways in which we can establish these types of forums. We have an early researchers and integrated care network, which I think is going to be fantastic, which is really supporting young early stage researchers with their master's projects or PhD projects, and working with universities worldwide to bring these cohorts together. And for me that's fantastic, because if I can get 50, 60 students a year from all over the world working as part of that network, then in 10 years time I've got 600 foot soldiers out there doing the work of integrated care. This is about the movement, and it's also supporting them. So this is very exciting. So there's a lot of effort the foundation's going to put in over the next 3 years to support the knowledge, and also to get to understand and know all of our participants and what their needs are, because we think we know a little bit what they are, but actually we don't really. So forums like this are really helpful for us to find out what it is you really are looking for and what you really need. I think I won't say any more than that, but maybe who can I look to? Oh, I think one of the really interesting things actually is how we're growing. So yeah, I'm getting a new position in Australia, but actually it's part of the growth of the foundation, because we have the growth of these collaborative centres and hubs in different parts of the world where we're getting the partnerships coming together. So you heard about Canada, a North American hub. It's really beginning to grow. We've had discussions this week for Latin America. Obviously, we're growing from Australia to look at the Asia Pacific. And our modus operandi there is for IFIC to work with a third party, a university or an NGO or a collaboration, and through those collaborations develop regional or country-specific set of activities according to the needs and the priorities of the group in those localities. So they're all slightly different flavours. So in Australia there's a lot of issues around advocacy and knowledge sharing. In Canada the focus very much on people-driven care. In Scotland there's other flavours again. Often older people is a very strong theme. Coaching and system leadership. So everyone's slightly different depending on the conversations that you have, and that's absolutely fine. But what I like about them is they're bringing lots of different partners together in order to have conversations. Like this conference, one of the things that we've tried to achieve is to create a space whereby you can have your PhDs and academics and researchers, but they're in the same room as professionals and managers and policy makers, potentially, and maybe industry people, like Hector's down there, and you're having this conversation, and the conversation is always, or usually, entirely positive, because you're trying to find those solutions and those ideas to things of common concern. And that's just really important to us. So the space that we're in this conference is unusual to other sorts of conferences, and I think it's vibrant as a result of that. And that's kind of what we want to achieve through the board and through the collaborative centres, is we're creating spaces for all parties to come together. And I think there are things that we want to focus on a bit more, like the role of users and carers, and having a greater patient and user voice through what we do. Very important. We've tried to do that through the conferences, but I think we need to do it through our other work as well. We've thought of that, and a few other priorities that we're thinking of doing for the next few years. So it's really interesting. But maybe if I come to Anne and then to David, and then maybe we open up to a conversation a bit, just to say a little bit about the collaborative centres, because we kind of thought, let's do it, and they've emerged in different ways, but both very positively. So Anne, you've got so many activities going on in Scotland, or through Scotland, I should say.
So we, following hosting the conference in Edinburgh in 2015, we wanted to build a legacy after that conference within Scotland. So a number of our national partners got together in a room with Nick and really made a commitment to try and establish an IFIC hub within Scotland. And at that point, I was the full-time Scottish Government role, but was beginning to evolve to a more part-time role. So I had a one-day-a-week commitment to support establishing and growing IFIC's hub in Scotland. And the first thing we did was we looked for a host, because we felt it wasn't appropriate for it to sit in government. And so we cast the net around for an interested academic partner and actually landed with really a collaborative arrangement. So the University of the West of Scotland officially is our host partner, but actually we've got a very strong relationship with the Health and Social Care Alliance, our national third sector umbrella organisation. And I think that's probably one of our unique selling points, in that IFIC has very many academic partners across the globe. But with our Health and Care Alliance partnership, we have a very well developed, a 10-year now relationship with the Health and Social Care Alliance, the voice of lived experience in Scotland of people who are using health and social care services. And then our other core partner who provides support in kind is the Institute of Research and Innovation in Social Services. And again, that was a strategic move, because we felt that at conferences, the voice of social services was not as strong as the voice of health services and health management. So it was a deliberate move to try and get social services and third sector at our core. We have very many other national partners across our advisory group, and they represent policy, delivery, leadership, education, quality improvement, and most recently we've invited Helen as our representative from housing sector, because if we're serious about population health, then the role of housing providers is very critical. So we're still growing. We officially launched, and David was kind enough to be at our official launch in 2017, so we're about 2 years. And one of our first products was, with the support and advice of IFIC and of Robin from University of Birmingham, we've established a Masters in Leading People-Centred Integrated Care. So our first cohort is going through that. That builds on a very successful undergraduate bachelor's in integrated health and social care. So it was really a nice development of that undergraduate programme into a master's programme, which is available online. So while our students at the moment are local to Scotland, there's absolutely no reason why people from elsewhere couldn't participate in that master's. We are in the process of positioning some of the master's modules to be credit-bearing CPD for people who perhaps don't quite want to make a commitment to a master's, but might want to have some modules in the bank for a rainy day. So we're in the process of doing that, but in conversation with our colleagues from IFIC Ireland, because we think it's a very similar market, and it would be a bit crazy for us to develop something in Scotland and then you develop something separate in Ireland. So as yesterday, we're just continuing that conversation about what we might do together in that CPD space. The other area of work that we've progressed, as Nick mentioned, is the webinar series. When I first started coming to IFIC conferences, I struggled to find the healthcare practitioner. I found plenty of them who were in perhaps a policy role, but people who were GPs or community nurses, allied health professionals weren't very visible. So we thought we had to do something to particularly reel in the jobbing practitioners into the community. So we developed a webinar series, which is our kind of Integrated Care Matters Home and Away series. So presentation from Scotland or Ireland now, because we're doing them now with Ireland, and a presentation from somewhere else in the world. So we've had colleagues from Singapore, colleagues from Australia, New Zealand have presented in a sort of shared webinar. The time zones are a nightmare, so huge thanks to many of you that stay up very late at night to contribute, but we're now able to pre-record and to have them on the Zoom platform, which is much better technically than the previous WebEx. And they are now uploaded and available on the IFIC Scotland page of the IFIC website for you to use. And the feedback we got when we evaluated the second series had said that this is becoming a really useful resource for getting your accreditation, revalidation, or for use in some of the undergraduate teaching. So that's a resource that's there to be used. And then the other area that we kind of developed is to lead on establishing a few special interest groups that link to our comfort zones, which have been very much around older people, dementia, frailty, intermediate care, polypharmacy, a new special interest group last year on palliative and end-of-life care, and in fact 3 that launched this week, one on self-management and co-production that is being led by the Alliance, by the third sector. One on compassionate communities that's launching tomorrow in partnership with the University of Deusto and the very vibrant compassionate communities led by the New Health Foundation in Spain. And one that we launched this morning, which is going to look at integrated care in small islands. And I know Australia's an island, but it's not really that small. So we're kind of looking at the kind of under 500,000 population. And that's been co-led by Seychelles, by the Isle of Man, and by Scotland. And we've already hooked in Croatia with its 1,000 islands, and Malta. Our colleagues in Malta are very interested. So we're hoping to grow that, because I think there are some real challenges, but as a colleague from Malta said this morning, some fantastic opportunities for small islands to show how integrated care can actually be done really well. The other two areas of work are, we are putting our toe in the water in research and evaluation. To be honest, we're much more comfortable around knowledge exchange and implementation support than we are around research. But we have had no core funding, but because I've been leading for UK on a European joint action on frailty, we've been able to lever in some funding from the European Commission, and that's supported some infrastructure. So we've brought the joint action advantage to IFIC, as it were, and that's been a really productive conversation, I think, mutually. And we've also supported David's team in the evaluation work that you've been doing in Central Coast. And our first evaluation project of our own was on compassionate Inverclyde, and we were dead chuffed to have heard that got best paper, and our evaluation kind of helped with that. And we're doing a nice little piece of work with Helen's organisation, beginning to look at some action research around community hubs, housing as a community wellbeing hub. Finally, the other exciting area that is probably my joy is that bit of system coaching. For the last 10 years, I've worked with every partnership in Scotland around holding up the mirror to their journey for transformation in health and social care. And it's a real privilege to be able to do something very similar with systems out with Scotland. So we've supported Nick and IFIC with some of the work in North New South Wales, North Coast. And we've been doing some work through the IDB with a couple of systems in Brazil, which is amazing. And through WHO, we've been doing some work as well on ageing, and also with their integrated people-centred health system working with Seychelles, and also led the first practice brief for the WHO Global Framework, so we produced that for WHO. So it's been a total blast for the last 2 years. It's a great thing. I can't say any more than just go and create your Asia Pacific Hub and have a great time working with Nick and the team. And we're so excited to be welcoming Tony back to Scotland.
Yeah. So we've done a lot of talking. I think it's probably time for conversational questions. Or
can I get you to expand on? I may have missed things you said.
Sorry, Harry, my voice is gone, Harry.
So I look at this from that perspective, and I think you made some rather negative remarks about clinicians getting involved in integrated care, and I see it, the bastions of university faculties, medicine. We need help to get. Doctors need to understand this, even if they're not involved in it, don't they?
Yeah.
And in our curriculum, our medical school curriculum, they see virtually nothing about integrated care.
Yeah.
And I think if we leave them behind, it's dangerous. You've got to have medical support, I think. And you may have more experience about getting this into undergraduate programs, but I think that's key. And what scares me witless is I work with orthopedic surgeons who've done the same 10 years of training as I have, and yet our jobs couldn't be more different. And you do more postgraduate medical degrees, don't you?
Yeah, I mean, I work for a regional university, the University of Newcastle, that's a small is beautiful research intensive university. And I guess back 30, 40 years ago, it was an innovator in moving towards problem-focused training rather than, as it were, training people to be scientists and hoping that they would suddenly become great clinicians.
Yeah.
But I guess the reason we're involved is that at one level there's an appalling Australian comment. It seems to be a no-brainer that if you design a set of services around subspecialist providers, when you are trying to care for people with complex social, environmental, economic, medical, and other sorts of problems, that the outcomes are not likely to be optimal. But you know, in the Australian context, we are in a situation which is partly culturally determined by the biomedical, so-called evidence-based approach to medicine, to funding, to investment, and to all those sorts of things. And we are seeing an enormous amount of generous, imaginative problem solving at the local level. Hence 90 people from Australia came to this conference, and many of them have climbed for several mountains in order to create a, if you like, a patient-centered, sensitive, effective local system. But actually we're fighting major difficulties with the, if you like, the funding, the mechanisms, the alignments for reward, the volume-focused investments, and the short-termism, if you like, that determines much of what happens from the top down. So I guess what we've been trying to do is to create a collaborative set of people who will address really the turning around of the healthcare system from where they are, from what their interests are. So that might be St Vincent's Mental Health Services in Sydney. It might be the smallest and strangest centre for rural and remote mental health based in Orange in New South Wales. It might be the people in mid-North Coast, New South Wales. But so we are trying to create a local capability and a set of relationships such that we are able to encourage people and to bring people working collaboratively, both nationally. And so Tessa was talking to us recently, and we scratch our heads and say, how do we bring lawyers into the fold? You know, and what does that mean? My group are interested in questions like, how does water security impact on integrated care? So how does suicide prevention relate to integrated care? So we are basically looking to create, if you like, a supportive capability and a partnership of interested parties. And one of the ways in which we're doing that is that, as Nick said, access to the Foundation's materials is free for individuals, but we are recruiting partners. And you know, the benefits of partners is you get, if you like, a steering possibility. So we have partnership rates ranging from bronze to gold, from 15,000 to nearer 50,000. And for that you get a series of benefits, but you become, as it were, part of an Australian steering group, and you begin to have a mechanism for determining the priorities. And so, to give you an example, one of the priorities that's of major interest is to say, what does integrated care mean in the Australian context? You know, we know what it means in a unitary context like England or Scotland or New Zealand, where it's possible to shove money from general practice and take it across into community care or into hospital care to some extent. But I mean, that is almost impossible in the Australian system due to all sorts of things. So what we are trying to do is to bring together a set of interested parties, and we have a number of partners. There are two sorts. One is paying partners, but some organisations simply don't have money. So to give an example, we've just joined with the major industry body, the Australian Health and Hospitals Association. who are networked to everybody in Australia, essentially. And so we are working in collaboration with them. What they offer is their policy influence and their policy analysis and their networking and communications capability. And as well, what we offer is a unique and interested view on what can be done to, as it were, begin to make real substantive, I use the phrase progressive implementation. You know, it's different to pilots. We're actually looking to build change that will stand the test of time. And the test of time, as I see it, is that, particularly from my interests, people who have physical and psychological and mental disturbances and comorbidities and dual diagnoses will actually see an improvement in their care and a movement towards more optimal life experience than they currently have. But for other people it looks very, very different, because you know the reversing of the bandwagon, as it were, of the juggernaut is actually very significant, very hard. We're also looking to build capability, and so Nick mentioned the accelerated learning workshops, and we're also doing them in rural places, but what we do is invite 4 or 5 people to come from your team, and they work on something for a week with international support, but with peer support. And to give you an example, we had a team come from Western Sydney who wanted to work last year on palliative and end-of-life care, including clinicians, general practitioners, but right across the partners. And we did pre-work, they did work over a week, and they left with a coherent plan of action to do something. So we're trying, in a sense, to be, if you like, facilitators, to be catalysts, and you know, we're having to run the partnership type thing because we need minimal resources. You know, people can't fly from England or from Scotland or from wherever it might be for nothing. And we also, at the moment, have effectively a 2-day-a-week administrator, and I've been doing a little bit of, you know, when you're the director, you can, what's the word, be flexible with people's job loads from time. But you know, what we are trying to do is to create that Australian, New Zealand, Oceanic movement for change that will be authentic and will be sustainable, but that will actually make a difference. And maybe just one last comment. You know, this is about working collaboratively, and we really are genuinely interested in listening. So, you know, please tell us how the world seems to you, and what you seem to think are what you think are the priorities, or indeed what you think are the areas where we might exert useful leverage.
Yeah, and that just does go for everything that we do, I think.
David, I think we need to talk.
What have I done?
So I come from an institute of 170 researchers who are mainly focused on health services, health systems research. We have an NHMRC partnership centre in health systems sustainability, which covers 5 states of Australia. That's a $10 million grant over 5 years, so it's not a whole lot of money, but it's something that we're leveraging off. And I mean, the things that we're concerned about is not only integrated care, because integrated care is one way of improving sustainability, but things like reducing waste in the system, using AI and you know, big data, you know, reducing waste and harm in the system and so on. So I wonder whether there might be some overlap and potentially, you know, some collaborations. We also embody a lot of methodological expertise, so complexity science, implementation science. We do a lot of evaluations. We also have the Centre for Health Economics at Macquarie University, and we work quite closely with them. So, yeah, I mean, we're really interested in what IFIC does, and looking for potential, you know, synergies and potential partnerships maybe. And I guess we don't want to be reinventing wheels. just an observation around IFIC and what I've heard over the last 3 days. It's incredibly impressive. But I think what could be improved is the methodological rigour around evaluation and implementation science. There's a lot of talk about developing models, but 10 years down the track, we really need to be looking to demonstrating outcomes and impacts on, the system, the patient.
I think, no, you've hit on a really important thing. So, when we started out on this journey, we didn't even know what integrated care was and how we would define it, what it would mean. But as we've gone along, this is a complex service innovation when you do it. So what are the methodologies and the approaches that we can do to really understand the impact? And we know that implementation science, not just in integrated care, but in general, is really very poor. So part of the mission to advance the science, for me, it's how do we advance integrated care or population health? These are scientific disciplines of thinking. And therefore, what are the methodologies and approaches that we need to take? And implementation science, it's just so very important. So we've worked a little bit on that, but we're really in the foothills of that understanding. And at the moment, one of the things we're going to try to do is curate. We talked about this. We've probably got maybe 30, 40 different types of assessment tools now for understanding how we think about implementation concepts. And we've heard some of them like Sirocco tools and how we do things. And not really implementation science, kind of guidance on how we do things. So how do we at least curate that knowledge to see what sorts of these tools work in what sort of context and why would you use them and when would you use them? But trying to find and fund, this is where we need to work together to try to find funding for implementation science itself. Because unless we fund it, we won't have the observational or the sorts of methodology that we can do to find out the answers to some of these questions. And you can only do it through kind of real-time observations with a different type of methodology, but people don't fund that kind of activity as much as the usual summative research. But really important.
Excuse me, before we move on, quite a few of our colleagues are here from 315. Can we just let them know what's happening, whether they should join us?
Sorry, I misheard that.
So we've got a lot of our colleagues who are up in the back for the 315 meeting. Can we just let them know
whether
they should come and join us or not?
We can. Okay. 30 meeting, I think.
So while it's saying that, attending to that, I wonder if we problematise it a bit much. I'm a hospital manager. Why not go out to people and say, work on integrating the care in front of you? There's big internal barriers within our organisations. Our community of interest is quite constrained and visible, but we don't necessarily engage it, we don't drive it in the patient-centred sense. So I think, although the high-level stuff's hugely important and creates the ultimate enabler, in the meantime, local validation is within our hands and within our purview. And I think that way we can develop a cohort of people with skills, knowledge, understanding, and frankly, they will demand it.
Yeah. We certainly have a lot of case studies that have been written by people who are undertaking integrated care in Australia. And the purpose of those case studies is to share and systematise.
So I'm also saying not just knowing how to do, but actually learning how to do by doing.
Oh, exactly.
And so I think it's important to see this as a very enabling set of ideas and concepts that we can go out and use, albeit naively, stupidly, hopelessly to start with. But we can, with a bit of guidance and a bit of support, make a big difference. And
the evaluation side then comes in, because my colleagues who sit on the district hospital board say, they want to look at acute medical bed days or readmissions for something that they can do it, make it a
They've just said they don't.
What we're doing is not describing describable in an equation. This is a social program.
Can I-
They look at big hospitals in bed days and change. They ignore the fact that the population has increased by 10% and that 20% of them are now living in deprivation indices and lower. So the whole thing becomes obscured by...
If you seek permission, absolutely. It's better to be like the Jesuits and seek forgiveness rather than permission.
Are you talking about subversion?
Can I?
This is very.
Can I invite the? Sorry, can I just need to get my colleague. We're having a discussion in the round about the future of the foundation and getting involved, and we're kind of morphing this with the discussion around IFIC Asia Pacific. So we're bringing some more tables. So I know you're going to be slightly on stage, but we're not going to televise. Well, we might. But can you want to come down and then we can all have a discussion together and we can have that. So please don't come round the round table. Hector, if you want to, or you're happy there. So please do. And we'll get as many chairs as we can.
We've got excellent examples in Australia of local problem solving and building of integrated patient-centered services. One of my experiences has been that these have not been replicated in a similar form in other places. And so I point out half a dozen places where something is far better than the norm and has been sustained. But what we are having difficulty with is actually at a home level. And one of the issues is that we do need to communicate with the top as well as the bottom. That's not to say that
Not arguing against that, but in the meantime, those people who've moved on have taken that knowledge with them in this program. And, St. Columba.
But it really is this top-down versus the bottom-down. And I think everyone's coming to the realization of sustainability has to be one we have 17 integrated care partnerships with the population of 1.8. The population is about 100,000, and we've brought all the major players in each of those communities, including research users, providers, community providers, the third sector, and we're facilitating that process. And we've given broad brush strokes around frail elderly, diabetes, whatever, but we let them decide with their champions. And back to your question about the clinicians, you'll find the local clinicians, professionals and service users in your locality. And that's where it's driven and it comes up. And the problem about scaling up is a real one. We get incredible impatience from our department. Why are you not doing what is good for diabetes there and doing the same thing? I said, time. We need time. We need 5 years. We need the ability for those that have championed new pathways for frail elderly or diabetic care or peripheral vascular disease to be shared over a period of time. But I take your point, and we're trying to create a central database of what's good, but the population of 100K bottom up and given the time, and that's what we're trying to do. And the final thing is the issue of respect. Partnership is a real issue between the service users, the third sector, and the professionals, and there's a huge learning curve for our professionals to accept and respect the service user voice. We've been at this about 4 years, and there's now a growing consensus. How we take the politics out of it, and how we try and enable the funding to be shared more equitably. Our trust colleagues who want to reduce their ED activity, and there's long waiting lists, are starting to buy in and saying that there are advantages and sharing those things. But we haven't cracked the idea of the population health having a single capitated budget. That once we get to that mature stage and can share and agree But the transitional funding to comprise some very shift-left activity all the time, money gets drawn up. Local populations bottom up is what we're discovering for sustainability. Social prescribing, using the social assets that we have, I think huge value in our voluntary community sector, particularly around mental health. They don't need psychiatrists and psychologists with all due respect. We need activity and understanding and gentle counselling and support services, and that will bring sustainability to
So I think what you're saying, I think what I'm hearing, that might be wrong, is I think that, and with what you were saying as well, was I think a lot of what we develop as far as integrated care goes develops locally, because you know the players, you know the population, whatever that is. And I think it comes back maybe to what Nick and a few others were saying about the knowledge exchange and about learning from what has and hasn't worked and making it timely. As one who does publish, it can be 4 years or 6 years, by which time things have gone, anything's changed, including the government. So I think it's that knowledge exchange about what we can learn from each other. I think that's what we're saying. So that if you're looking at a different funding model and it's of interest to other people, how do we share that in a real time? And it's, I guess, how we share that in a real time way. That's kind of what we're getting to, isn't it?
I mean, that's part of it, but I think integrated care, any integrated care model has to be situated within a context, and so you really need to know your context extremely well through formative evaluation to be able to co-produce something that is likely to succeed. So something that works in Orange may not work, at the Macquarie Hospital, for instance, because it's a different context. But there may be components of what you do in Orange that can be transferred and adapted to the context at Macquarie. So it's a flexible thing.
And I guess what we're also trying to facilitate. What we're also trying to facilitate is the sort of conversations that say, comparing what happens in northern Sydney with what happens in a rural area may be nonsensical. We may need to be comparing what happens in rural Australia with what happens in rural Canada, with what happens where they're both federal systems. They've got snow, we've got sand. But nonetheless, the issues, the scale, are very different. And, from a rural perspective, we commonly say we are not mini metro. You have to understand the context in a much more sophisticated and nuanced fashion. And that the ability of being able to share on an international basis, to share expertise, to share methodologies, to share inspiration is part of what this is all about.
So, just want to welcome our new guests to this very large round, circle in the round, talk in the round. Apologies, we're kind of having private conversations. So what we've discussed so far is the kind of the role that we're trying to create for our hubs and collaborative centres. And I think one of the aspirations for the foundation is to begin to grow our activities in different regions of the world through forms of knowledge partnerships and forms of knowledge exchange. And we've been talking about it generally, but we can put it in the context of the Asia Pacific. And we're really looking to develop these collaborations in really kind of 3 tiers. So firstly, if there are conversations that we have going on, for example, as we have in Singapore, we have in Taiwan, not here today, we have in Hong Kong and New Zealand. We're going to try to build on those relationships to try to bring interested parties who are interested in integrated care to try to come into regional forums, whether they are remotely based, in order to create some form of interest to think through, well, how can these types of forums support your thinking in different parts of the Asia Pacific? And for the foundation, it's important for us to try to grow these kind of regional hubs. So we're doing the same in North America. The North American hub with our Canadian partners who you heard earlier doing it before. We have our Latin American South group. We have Southern Europe. We have Belgium, Netherlands area, as well as the work in UK. So we're working as we go, but they're all very similar type of constructs in the sense that the foundation is trying to act as the hub through which these conversations can have. Obviously, I will be working in Australia and working with Tony in particular here to help us to grow sustainably some of these conversations that we have across the Asia Pacific, as others will be doing in the other regional centres. So level one is very much how do we bring together, we'll call it IFIC Asia Pacific, probably, could be something different, but then how do we bring together a forum on a regular basis to start to have conversations with people across the region, big region, and then work through that to think, well, what can we do locally? So I can easily see developing a kind of IFIC Singapore set of activities. Talk to the AIC, they're interested in education and training capacity building. You go to Taiwan, they're interested in understanding about long-term care and how we can move from very much a hospital-centric system to something that's more based in the community, really very interested in that. So every country's got a different flavour. So the first one is just to create a platform for those discussions. And then if there are parts of those systems where we want to create something more tangible, as we've done in Scotland and we've done in Australia and other parts of the world, then the second one is to begin to create a formal collaborative centre between IFIC and the partners in that area, normally a university or a third sector agency as we had. So in Canada it's the University of Toronto and the Change Foundation, in Scotland it's the University and potentially Health and Social Care Alliance, we're hoping, with the university. And so we create it, and that means we were able to create a little bit of a centre with a resource so that actually we can begin to help to manage these activities, because it can't happen simply off our own work. So we have to try to invest a little bit in a relatively small amount of resource to help us coordinate the network and do things like webinars and knowledge sharing and special interest groups and other sorts of frameworks. So we begin to grow the knowledge sharing activities. And then as we grow again, we might become more ambitious in order to be able to develop the educational programs or do research collaboratives and begin to drive. And in the more ambitious one, that's when we bring the partners together to help give us the priorities in those local contexts of what we might want to do. But it's really an open field as to the nature of the conversations we take forward, because we take that inspiration from you. We're here as a facilitation and a network exchange kind of experience with a bit of knowledge, but really the knowledge is, and the strength of the knowledge is in the partnerships that are formed, and it's our job to try to develop those partnerships. That's how I see it kind of developing in a sustainable way, and it can easily just stay as a level one. We get together occasionally, interested individuals, but I think if we have an aspiration to grow the right types of research, we have the aspiration to have education and training that builds new types of professionals in the system that understand and inbred in their DNA is a different way of thinking and working, then these are the sorts of things that will take another 10, 15 years to do it, but let's do it because it's important. So we can pick and choose the things that we want as our own priorities. That's my feeling of it, and I think it's our current thinking. And you see it's not difficult to understand. It's aspirational, but I guess this meeting was to get your ideas, and we're hearing lots of ideas, discursive ideas, but also to ask us questions around what is it that we might do, what could we do, your advice, and I can hear 3 or 4 different types of advice, so we're logging that in our brains. So we'll really, who would like to? It's our colleague from Scotland.
You won't be able to hear me, I've got such a quiet voice. Could I make an observation? And forgive me, I'm quite new. So I found this afternoon very helpful in terms of describing the history of IFIC. So I chaired a very interesting set of presentations this morning. There were 5. And I'm probably talking quite elementary, so perhaps you're doing this already. But of those 5, there were at least 4 that had so many things within them that you couldn't, I don't think the audience, we would have time to ask as many questions as were needed. And yet, of those 5 presenters, the knowledge on some basic areas that could be shared amongst even that small group would have been quite good if we'd created another workshop just for those 5 to talk about. And you talked about the involvement of clinicians, or we talked this morning about very simple assistance for people who are being discharged from hospital. And someone said to the other, one presenter said to the other, "But how did you do that?" And it was all about the provision of meals and the provision of actually check and see whether the person had their electricity or their fuel or whatever. So there are so many basic questions like that that people would find helpful. And I thought to myself, if only I could then convene another forum for those speakers there. But
you have the opportunity. One of the things that you learn from a conference like this is it snowballs to all sorts of other things.
Yeah.
So I had someone from Norway come up to me and said, you know that meeting that we had and the contact that we had, they now have their own forum that they've developed that's built up over 6 years, which have a couple of hundred members. And you say, it all started from this little thing. So you're having that conversation, you're connecting with 4 or 5 people.
Yes. So
you've got to go for it. So, and then if you're thinking, can the foundation help by creating some more in-depth resource and workshops, you come to us and then we'll see what we can do to make that happen.
Yeah, because this just a small point I was going to make, and you probably do this already, is that even just for the groups to have for nothing too formal, but informal, short-term, maybe one meeting as a webinar, and that's all they would need. But the formal is as good as the informal, but you probably do that already, so again, forgive me if I'm already covering pieces that you've done.
No, not at all. I mean, I think the way to think about the foundation is it's a platform to help you to have those conversations and fulfill those aspirations. So you're in the group, and you're in a conference environment. You've got 10 minutes to describe something. You're never going to get into the depth. And we probably need more networking opportunities in the conference to discuss things in more depth. There's a lot of content. I mean, it's good content, but yeah, we need those discussions. So we'd love to get that feedback, because if there's something that we can do on that particular subject, we've got special interest groups, we've got webinars, we've got opportunities in which we can do to generate that knowledge. And
So that's not an uncommon reflection, Helen, and in response to that experience in previous conferences, what we've organised this time was a study day on Friday, which was for members of 2 special interest groups to come together and have a full day of networking, and a post-conference study day tomorrow with another set of special interest group members. And I think it's just trying to find opportunities to create the space.
Sorry, just a quick question. Because you mentioned some of the collaborations with Singapore and Taiwan. So what else and how else can Asia Pacific countries contribute besides the webinars, the conferences, and also besides some of these countries which are more developed, how else can developing countries be included to IFIC or to others? Any thoughts?
Just in the last few days, I've been asked to participate in like 4 or 5 Zoom sessions, because we couldn't get down to the level of, that's a fantastic concept, but how do you actually do it? And I think other countries being involved in the how do you actually do that, how did that happen, would be very beneficial for you and beneficial for us.
Yeah. So we're here to create this environment for you. So the way you do it is you come to us and you say, what is it that you're needing in Singapore that helps you to connect together? And one of the opportunities that we have in creating the connection in Singapore would be to bring the people together and begin to ask those questions. So it's absolutely open, but you have to take the initiative and come to us. This is not design and build. This is co-production and co-evolution of ideas with the partners in the localities. So it's an open book. You can think of it like that.
Thanks, Nick. That's really sort of partially observations and also questions, is perhaps more in the Australian context, but equally for wider Australia Pacific. Who are the competitors for IFIC? And what's being done about those? Because we talk about partnership and co-production, but there actually seems to me you've got competitors, and what do we need as IFIC to do about that? And so, for example, is competitors, I'm meaning in the Australian context, you've got organisations such as the Agency for Clinical Innovation, you've got Safer Care Victoria, you've got the Institute for Primary Care and Equity, you've got various research bodies, you've got all of these, the AIHI at Macquarie University. So that one thing there. Second one is that, and this is rude of me to say this because this is the first IFIC conference I've been to, but it does seem to me that there's a lot of the converted talking to the converted. And so what's happening about getting those that actually don't understand that it's even something they should be thinking about, and getting them on board. Then in the Australian context in particular, we've got two great opportunities, a Royal Commission into Aged Care and a Royal Commission into Disability Services, and I doubt very much that integrated care is on their agenda at all as yet, and so there'll be some opportunities that should not be lost. And then finally is what can IFIC do about advocacy to outside the health and social care system, which is going outside the converted, so that we have got other levers in Australian and Asia Pacific society, government, treasurers, politicians, industry, the Business Council of Australia, seeing that integrated care is actually of benefit to a nation, not just to a health system.
Well, I can give my thoughts. Maybe David wants to respond. As my co-director in Australia, the issue of competition is an interesting one. That's not our modus operandi. We're not in it to compete with anyone. So if there are opportunities for the ACI, who's actually a partner of ours, or for others who want to be able to, or the Marta Research Institute could be a competitor. But it's not, because we're thinking, are there things that we could do constructively together that are going to be to the benefit of both parties? And there will be people who don't work with us, and there are plenty who think we're competitors. That's fine, but that's not the way that we operate. We're there to be able to get free and open access to all of this information, right? So you come to IFIC because we're the brand, we're the honest broker to be able to put all of this together. So if other people want to compete with us and create their own forums, that's absolutely fine, and we'll put it on the website and you can go to them and this is what they're doing. So it's the opposite. You know, sometimes when you create a website and you want people and you capture them into the website because they want you within that, we're kind of the opposite of that. We've got to be able to bring this information and flower it out to the others. Now, the business model around that is a bit more challenging, but the philosophy, we have to keep that philosophy. IFIC will not be IFIC if we start to act in that kind of competitive environment. So if we are going to work with our partners, I will immediately go to say, is there something that we can do together that allows us to do it? Now, IFIC is a global network, so if we come to some of these organizations in different countries, most of them are seeking an international platform through which to be able to distribute and learn their materials, whether it's through a journal or through education and training or through some of these research and other things. Well, we can offer that in a network that is global. So they will work with us because there is an opportunity for them to gain credibility and kudos through the relationships that we can broker. And we want to work with them because they've got all of the capacity and interest locally that will help to do that. And we've got to make those kind of conversations. So I mean, David, so I don't feel that, you know, that the competition is a problem for us. Not at this stage, but because, you know, are we preaching to, of course we're preaching to the converted, but it's 1,500 people. When I was preaching to the converted 20 years ago when we started, it was 12. So we're getting somewhere. But you're right. So there's the issue of implementation science, change management methodologies, the solutions products that we're developing. So we're really focusing in on how and coaching activities that Anne's leading. So we're focusing in quite a lot of our effort around if we're going to seek to develop innovations in a particular place to deal with a public health problem, whatever it is, how do we find the methodologies to support the managers or the coordinators or the people who are going to be doing this in practice? What can they do to kind of do a stakeholder analysis to understand who they're going to influence and how to bring people together to solve a problem. And this is help that we can provide. It's not us who are going to do it. It's you guys are going to have to be able to do it, but we can provide that support. How do we provide that support? We've got some conceptual knowledge, and we've got some understanding, but we've got people who've done it. So we bring the people who've done it. You sit down with those people. How were you able to convince this? How were you able to do that? And a lot of integrated care is a journey. It's a really difficult journey, but the learning and the strength of integrated care projects that have survived and thrived has been through the journey of the development of it in your own particular context with the partners who you have. And that's another really interesting kind of thought around that. But we certainly, this is the sort of support that we would provide, and the accelerated learning programs is a bit of that.
I guess also responding, one of the things I've been interested in over the years is why do extraordinary things happen in particular places? You know, why Torbay? Why Christchurch? One very interesting development is that Nick's going to a position which is the Central Coast of New South Wales Health District, who we've been working with and doing evaluations with, who concluded they would like to have a research unit within the health district and the university. And through the integrated care connections, two things have happened. One is that this is not a biomedical research institute, which is the normal pathway. This is a research unit into population health care and integrated care. And secondly, building on work we've been doing with the Central Coast over a number of years. Nick is coming in as the director, working for both the university and the health district. Now, I take that as an example because it seems to me that we are trying to build partnerships that will facilitate extraordinary developments in particular places, but that we also recognise that there are things like the Productivity Commission and the aged care and the disability. And so, you know, the building of the partnership and a minimal level of resource provides a level of flexibility to do something. And to give you another example, for instance, we were able to work using the European Developed Project Integrate material to provide a framework for working with the Central Coast of New South Wales, with permission, with support. So there was a considerable degree of sharing. Now, where I struggle, and you know, where there's been a challenge for IFIC over the last 10 years I've been a director, or 100 years or whatever it's been, is that it's moved from almost nothing and from no infrastructure, from no major external infrastructural grants, you know, trying to work out, can you afford to pay the wages, can you, all that sort of stuff, to, to a situation where, it's a $2 million a year organisation or whatever, which isn't very big for a international organisation. So I guess that the challenge we're facing is, trying to identify who are the people who are likely to want to work with us, who can develop the resources, but with the intention not that integrated care is not the final objective. The final objective is the quadruple aim. It's better care for individuals, better health for populations, better use of resources, and actually a set of people, whether they're carers or whether they're partners or whether they are health service staff or community and other sector staff, for whom their lives are manageable and rewarding. So it seems to me that the same objectives stand, but the integrated care is maybe a pathway.
So, very important comments you're making. I think the other thing is going back to what IFIC is, and the others we didn't describe coming in. So we're a Dutch-based organisation. We're kind of like a public benefit organisation. We have a board of directors. Albert is the chair. David's been on the board for some time, and we're not owners of the business. We're custodians of what is a public benefit organisation that's bound by the statutes which we've put down, and the statutes there are related to how we can improve health and well-being through people, for people, by advancing the science, knowledge and adoption of integrated care and policy and practice around the world. So everything that we have to do has to fit into that space. Now, as a philosophy, competition and integration doesn't necessarily go well together. So there's a certain way of working that we have to try to adopt and run. But there's room for everybody within that. You talked about advocacy, absolutely. And originally when we set ourselves up, Albert will agree, we were kind of a knowledge sharing type of group. But we've grown up a bit now, and we said we're 19 years old, so we're getting a bit ballsy, and now it's time to do some more advocacy, and certainly in Australia. So we're just going to start a series of what's it going to take to take integrated care forward in Australia. And we think using the IFIC kind of international thing, we might get a bit more traction than if it came from a local university. So that's definitely something we're on. And I know we've talked about doing it a bit more centrally as well, because we've kind of been quite polite that integrated care is a quality improvement tool and it might support this and that. Well, actually, the sorts of care and support that we provide to vulnerable people is shocking. It's absolutely appalling, almost in every country around the world. So we need to be able to create some of these really more person-centered, user-centered stories to be able to demonstrate just how shocking it is, and then find what is it that we can do differently as a platform for change, and really become a little bit stronger in the advocacy role as other kind of organizations do. So I think we'll be doing, at least in theory, doing a bit more of that to create that kind of compelling case, you know.
Thanks, Nick. I'm Philip Hurl from Sydney. People may not be aware, but there's a ministerial group called the Australian Commission on Safety and Quality in Healthcare that has just released and implemented new National Healthcare Standards, version 2. And they require every hospital and health facility, larger pretty much than a medical practice, to implement patient-centred care, comprehensive care, co-design of care in terms of their systems, and co-production of care at delivery. We're all floundering somewhat with this. What does it mean? Which way up? Which way down? But for me, I came here very worried about that. I'm going away knowing what to worry about, which is fantastic. So I think that there is actually, in a sense, and quite rightly, the Australian governments have said, well, it's so complex, the only people who can solve it are the people who run it. So go solve this, and by the way, you've got to. And it'll be very interesting to see what comes out. You have to be accredited to be able to bill. And furthermore, if you're a manager, you have to be accredited to keep your job. So it's quite a powerful forcing function. And possibly the Commission is a group that one approaches them with great caution because they're in a different business. But they may well be a group that could be useful to at least have an mutual understanding with.
This is changing direction a bit, but I've been slightly disappointed by the lack of attention here to what I think in Australia's same problem we have. Our hospitals are full of middle-aged people who live in deprivation and who are obese with 4 morbidities. And everything I've seen here has been frail elderly, and I can be kind of negative here because I'm frail elderly. But in a way, they're easier because these are people of 40 with diabetes, heart disease, obstructive sleep apnea, and there are 3 generations in their households and the dependents, whereas the 80-year-olds have got pension and they own their own house and the kids have gone. So I don't know whether people have the same issues, but I bet similar.
I mean, I think one issue is about what you actually end up going to in a conference like this. But I was chairing a session on mental health, for instance, and hearing how they were wrapping services around the most vulnerable people in Western Sydney who live in boarding houses. And I was very moved by that attempt because, in theory, I know that housing first is a very coherent and logical strategy for people who are in some sense homeless and who have mental health conditions, and that we often assume that we can treat people and then send them back, as was said, to the conditions from whence they came. And you know, we know that the outcomes are very disappointing. So I think we are seeing some of those developments, and certainly visiting Anne in Scotland last year and Compassionate Inverclyde, I was extraordinarily impressed by a project that is about end of life and elderly, where in very simple terms, vulnerable people help vulnerable people and they become less vulnerable. And I was almost in tears when a woman got up in a round meeting and said, I won't be able to come every day because I've got a part-time job. You know, and there was that sense of someone who in an enormously practical way had, you know, moved a step in her life in that sort of cycle of vulnerability by caring for other people. So I think we are seeing things that are not conventional, that are in, you know, that are in the lives of the strugglers rather than the lives of the pensioners with big superannuation. But, you know, and that is where sharing and being connected and actually being able to go and see something. And the other comment I was going to make is one of the things IFIC can do is connect you to people of your own tribe. And clearly, if you're part of a medical tribe or a hospital emergency medicine tribe or a psychology tribe or an NGO lawyer tribe, you know, it's a very different situation to be in than, you know, if you think you're being lectured by academics who've never done anything useful in their lives. So I think that issue of how this is an active international network of concerned people can be brought together and, you know, those synergies can be exercised is something that's very valuable.
Yeah. So it's really interesting. I mean, one of the issues with our conference, of course, is scientific conference, and you set up a number of different themes, and often it's quite uneven, so you can get 100 of one and 10 of the other. So it doesn't surprise me that even today we're dominated by looking at care for older people in the top 1% and chronic disease as a very high proportion of the papers and presentations. That just reflects the field of the research and the issues that people are trying to deal, particularly here in the Basque country, where the focus has been particularly on these issues. So that doesn't surprise me, that's the flavour you came to. But I think I speak for Tony and give Tony a hard job when he has to take over things, but one of our aspirations is to kind of create a knowledge observatory, so that if you came with that question, we would either have some sort of knowledge or library service that would connect you into the case studies and the evidence and the ideas around how do we deal with these really big thorny problems that you're talking about. And then there might not be a huge amount of stuff, but there might be 2 or 3 other projects that you might be able to find, and you could got a contact, you connect them, and that's how things can flow. So over the next 3 years, we're going to. Tony's nodding. It's very important that he's nodding. But it's really important for us because as we've grown, we haven't had the opportunity to curate all of this knowledge into something that's going to be useful for people. And I think that's a big aspiration for us next 3 years.
So just a very quick one before I forget. Just an observation around this conference and also the conference in Brisbane. I didn't see any negative results. I'm sure there are failures out there, and I think we really need to hear about models that have failed so that we don't repeat our mistakes.
We've actually had that feedback, and we've already been discussing maybe somehow factoring a stream, or, you know, not necessarily a stream, but just negative results, yeah, and just an honesty session, and yeah.
Learning experience.
Most integrated care comes up with negative results.
Yeah. I was.
That's not how it's presented.
I was quite thoughtful walking around the posters. I took a session out and I walked around the posters and was very struck with the very much richer mix of themes than appeared in the presentation sessions. And I think that might balance perhaps your perception, Harry, and maybe it's a question to the scientific committee, how we make more of the posters and maybe think about a facilitated poster walk, because there's a lot of effort goes in, often from some low and middle income countries, that I don't think we're giving them the best return on their investment.
Don't put the posters in the basement, and it takes a day to find out.
Absolutely, absolutely, and I think that point's been made.
Yeah. I know we're just limited with whatever space that we have, unfortunately. But next year we're actually going, and I know some people don't like it, but in Croatia it will be electronic posters. Again, it's due to space because the volume of posters that we have. We've over 400 posters here, which is fantastic because you get to see them and they get to come and, you know, but yeah, it's a lot to manage. But point taken, definitely we need to do more facilitation sessions with the posters.
I'd just like to underline what Yvonne said. I think last week I went to the IHR-BMJ conference in Glasgow. They've gone a long way down the track of understanding all the issues of why some things are bright spots and some things aren't, what the impact of context. They've got models, as I'm sure you know all this, but I think it would be really helpful for people doing integrated care if they really could get a primer. Maybe it's not the job of this conference, but certainly a taster or a connection with high level or really solid models, say, quality improvement and implementation science. So I think that's something that I would like to see, and that might answer some of the negative results as well, because if you do it rigorously and truly, you will find the negative results, which is really helpful. So that's one suggestion, just underlining, I guess, what Yvonne said.
I mean, that evaluation is super important because if things are not working, you really want to disinvest and be brave enough to disinvest in something that isn't working. So knowing that it's not working is super important.
Unfortunately, next year they overlap, so I can't go to both.
I just would like to add something that has been tackled here. So when I see where do you come from and where we come from, we are the privileged people in this world. So, I think one of the missions as well of IFIC is just to raise all the knowledge and the experiences we are collecting in a collective way. And this is why we try to develop the knowledge tree and maybe having an observatory. Observatories could be for research, but could be for the very starting countries that they are thinking about a reform for the future, you know, and what are the first steps to go through. So there are many reforms in the world. The other day I was in Bangkok and I talked to the Director General for Health Planning for the Ministry of Sri Lanka. So she came to me and said, well, we can develop integrated care, but we should start in a different point where you are, what you are explaining. You know? So there are many opportunities in the world. And this is the bank of knowledge that in the open way that we try to develop integrated care is the lessons learned from us, because we've been going on and years, it could be such an asset, not just for research as well, for the well-being of the populations of the most undeveloped countries. I think this is something that we have to, this is why the concept of network in IFIC is so powerful. And then we can take advantage of sharing this knowledge, because what's happening, well, I'm European and we've been working on that for years, trying to collect good practices, study visits, on and out, and then the topic of integrated care is evolved, you know. And now when I listen to things that happen in Australia and Canada, so today I was chairing a session with an experience in Alberta, and it was amazing. So I really learned a lot, me as a chair, and being the director of programs of IFIC. So I think we should value this group of people who we are, and this is why encouraging the creation of collaborative centers, non-competitive, we are not competing with anybody, and then creating hubs that facilitate these contextual things. We had conversations with South America. Maybe they've got some commonalities that we could bring there. We are talking about South Europe because they are culturally, geographically, climate is different. So I think there is lots of potential, and then the knowledge tree, collecting practices, what happens around the world, in a way that we have a useful tool. We have to categorize, we have to tag, we have to use a sort of, create a tool that's good for researchers, because we need this information, is there, and not these days here, there is lots of things that would be in grey literature, you know, it's not published anywhere. Right. So we have to collect that, because it's very important, because there is a big bias with the people who are able to explain things in England, and then in English, and today you've seen that here many people are struggling, yeah, and then what's published. And this is one of the functions I think that IFIC can contribute to.
Well, the point about the positive bias, that's an interesting one, because when we, very early stage, when we wanted to create the journal, where you reject 2/3 of the stuff, actually, particularly the ones with the positive bias when they're talking nonsense about what the results mean and how much they've done. But it was Ingvar Carlberg, he was a professor in Sweden, said one of the things we have to do is make sure that we underpin all of our activities with that kind of scientific value and rigor as best as we can. Because there's a lot of stuff out there that's not scientific that we still want to include in the fold because we want to be able to be positive and supportive in what people are thinking. So it's really interesting you said that. We're doing or supporting some work with the Nuffield Trust on the 1st of May. And the forum of about 50, 60 people is trying to describe why are the results in integrated care so bad. So it doesn't, I mean, the thing that when I get up to try to talk about integrated care, the biggest feedback is, but it's more expensive. The only thing that it improves is patient experience, is the only thing it improves. You know, and these sorts of things. And then I have to get up and someone comes out with another negative paper and they say, well, they tried integrated care over there and it didn't work. Tell me about it. So being a social scientist, you've got to say, well, let's dig into this black box of implementation and find out. One thing I do find here, I found frustrating, is that people are getting the negative or they're getting the neutral results and they're trying to put a positive spin on it. Because they're not saying, this could mean that it's not working. They're saying, oh, it might be because there's a maturity model at play and it needs a few more years. Or it might mean we need a longer time frame. Or maybe it's a bigger sample size. I don't necessarily buy that. It might be that actually the intervention they're looking at doesn't work. And the reason it's not working is because they haven't actually used the proper principles of an integrated care design or indeed an integrated care methodology. So if your methodology is a bit ropey and the project is immature and it's not necessarily doing things, you're going to get negative results. So I'm very interested that there's a positive bias going on, but maybe not so surprised.
And if it could help me, because when I go to the grand round in the hospital and present this stuff, that's what they say. They say, "Where's the RCT, Harry?"
Oh, RCT's let me come and well, that's a red flag to a bull, that one. RCTs and complex service innovations.
Well,
okay.
Could we have a one-page article on how you should evaluate these large social programs?
I think that's the sort of question we like receiving, because that's the sort of question where we can write a blog, where we can write an editorial for the journal. Yeah. I wanted to make another comment, and that was about comparing integrated care with normal care. I work in a field where people who have enduring mental health conditions routinely die 15 years early than everybody else, and from physical health conditions. And frankly, nobody seems to think it's a problem. And it's because their care is not integrated, their physical care is not provided, and because they are being treated by an inadequate single specialty model. So if you detect a little bit of anger in, so the fact that an integrated care model might not be able to demonstrate that it's better than a model for someone with a single, uncomplicated diagnosis who has been sorted and provided with the best care. So I think these issues about what constitutes adequate and good quality evidence, and for instance, where does the patient's experience come into that? It's all very well saying we collected this data and that we did this counting, but what does that mean for the partner at home who's looking after the patient, or the partner or the child whose parent is having to be looked after? So I think we need to be much more sophisticated in what we understand by, in inverted commas, scientific knowledge and also human value, if you like, or humanitarianism.
I mean, let's have a conversation, because it seems to me, I'm just looking at you, but it seems to me that there is something that the foundation could do, which is to create some clarity on appropriate methodologies and approaches to evaluating these activities, because I get so frustrated, and the idea of RCTs, by the time you've managed, for vulnerable populations, like in the case that Harry was just talking, there's no such thing as usual care. So the idea that you can kind of have an RCT with a stratified sample of one set of people over here and another set of people over here for people with complex chronic care problems and a whole range of social care issues in an environment of housing deprivation and a family situation, I mean, it becomes a little bit silly to try to do that. And when you do it, you begin to take out all of the complexity in order that you've got a comparable sample. So all of the people who we're really seeking to influence through integrated care are screened out of these big studies, and then they come up with a conclusion, and it's like integrated care does this, but so we need to be able to find the methodologies that helps us to embrace that complexity and diversity, because at the moment, if we're going down the standard route, we're not going to get that. So that's something we could definitely, I'd love to do that, actually.
Nick, last week we had a great talk from Trish Greenhow from Oxford, and she basically said, you can't fix complexity. Yeah. You can only start to understand it. Yeah. Maybe you could get her to come along and
no, we have. No, Trish has been involved a few times. Yeah, she gave a keynote at the Irish Forum we did. Now she's great. Getting her, she did something in Australia with actually Caroline's Forum about last year. So difficult to find. She's always hard to get, but yeah, she's a top person to have on complexity science. Yeah.
So just a quick introduction. I'm Denise Ferry. I'm the Director of Policy and Planning for the Victorian State Government in Australia. 2 points I really like to make. One is, I think, when I walk around the room and talk to people, I'm probably one of the very few bureaucrats that are actually at the conference. There are a lot of clinicians, there are a lot of people, involved in research, but one of the advocacy functions, perhaps for IFIC, is to start talking to bureaucrats a bit more. I presented with colleagues around our Health Links work we're doing in Victoria, which is a funding model reform to try and encourage integrated care in our hospital system. But I'm a bit stuck as well in trying to convince ministers and government, I work for government as a bureaucrat, but ministers, big G government, around why they should invest in integrated care. It takes time, it's local based, there's very little evidence to support grand reforms of funding. And so I'm looking to this organisation to help me tell that story in a much more robust, real-time, environment where I can go to ministers who change every 4 years in our state, 3 years at a federal level, about the benefits of actually investing differently, using what is a significant amount of hospital money to convert to an integrated care strategy. So I just think IFIC is a fantastic opportunity to think about how we engage, particularly in the Australian context, and the political environment and its advocacy role in that space.
It's a very fair challenge, and we've always struggled actually to get the policymakers in the conference, partly because of the time they have to commit to it. So what the strategy has often been, we did it in Catalonia, we did it in Mexico, we did it in Brussels very successfully actually, was we have separate meetings with the keynotes and bring the discussion to them in a different forum, because and they might come to give their political speeches, but they're not going to sit here and listen. Occasionally when they do listen, they think, well, that was really interesting. So we have to take it to a different forum. I don't think a conference like this is really going to attract the bureaucrats and the policymakers to come very often.
Well, I've been twice, so but it is a rare thing, and I think one of the challenges, particularly, and I'm really keen to think about the Melbourne conference, is an opportunity to actually engage in that bureaucratic, not necessarily ministerial, but certainly in the bureaucratic level of discussion.
Yeah. No, totally agree. Thank you.
And I'd like to add. So I am Hector Upegui. I am working for IBM Watson Health. But my comment is mainly echoing that of the policymakers, but now including other stakeholders that are normally missing in this type of conferences, and they are the risk carriers. So you might have health risk carriers, you might have workers' compensation risk carriers, and they are part of the social security field. I mean, I'm not talking about the commercial risk carriers. I'm talking about social security type of private organizations being part of. So good examples, workers' compensation in Australia. You have a lot of health insurance, social insurance carriers in Germany, in Finland, in Denmark. You have also workers' comp companies private insurance organizations acting in the field of the public area, like in Portugal, Belgium, Finland, Denmark, Norway. Now, these risk carriers are carrying a huge responsibility on taking care of disability management or taking care of health risks. In some situations, they are also part of the ecosystem of taking care of part of the integrated care service type of delivery, but they are also not included in this type of conferences. I worked 13 years for a reinsurance company, and when I was working on that reinsurance company, for those that don't know what is a reinsurance company is an insurance company of insurance companies. So normally they are very far away from the final user. And when I worked for this company, it was incredible. I mean, we lived in an ecosystem. We were always around reinsurance companies. And it was incredible to think that nobody knew or knows that world. And when we were inside that world, we thought that that world was everything. And you start to move, it's like a club. We met the same people in the reinsurance sector everywhere. We were everywhere. But because we were everywhere, we started to think that we were all, so to say. Now, as far as you start to come into the integrated care area, and I've been doing this already for 6 years or a little bit more, you start to meet the same people in the same places, which is okay, it's excellent, because, I mean, of course, this creates momentum. But the effort is how to evangelize and to bring other stakeholders that are also very important, because without the risk carriers, the governance and the financing of the system is not going to be influenced. I mean, it's very difficult to talk about integrated care for disability management if we don't include workers' comp companies, for instance, or if we don't include the health insurance carriers, that they have their own bias. They work with some different ethos and etc. I'm not saying it's better or worse, it's just different. We have to include them. So it's social policy makers, but it's also carriers. I think it's going to be also possible to invite them.
Hi, I'm just going to say something very quickly. I'm from Australia and I'm new to IFIC. So this is my first conference, and I'm just wondering if I'm the only dentist at this conference. Okay, great. It might have been mine. Anyway, I'm here to tell you, in Australia, when you come to Australia and we have the conference in Australia, we'll be including oral health.
Okay.
Okay. Yeah. It's time to put the mouth back into the body. Very important.
Yeah. It's really interesting because there are so many topics. So I mean, it's really quite dizzying. So at each conference, we try to pick themes, and we try to pick themes that are different every year. I think oral health is really important. But, you know, I'd like to focus on children in early life years with special needs. So it's obviously ripe for integrated care, and the work of schools and this kind of thing, personal thing. But have we looked at that? Not very much, a little bit in Brisbane. The topics you've been talking about, some of these big thorny issues. But one of the things we've tried to gravitate away from, slightly different here because the Basque country has a way of what their focus is, but we've tried to move away to themes that are integrated care but are different. So over the last years, empowering and engaging communities and people in co-production, or issues related to value, as opposed to, you know, so moving away from the usual suspects of what integrated care was supposed to mean in the past, and always trying to push the envelope a little bit. Just push the envelope a little bit, because you can't drag people over to position Z before taking them on a journey. And I think it's really important to pitch it right, but I agree with you, over the years we haven't had much on oral health, so it's really helpful to hear that. Thank you for coming.
Can I pick up on that, Nick? Reflection from the week, and something I'd love to see in the Australia Pacific agenda going forward. as you build a movement, you've got people who've been doing this for 20 years and you've got people who are first at the table. It's their first time at the table. And so interesting to hear your comment about the outcomes being only about patient experience, because most of the sessions I went to, that wasn't part of the discussion at all.
Oh, really?
And so there were these very clear, detailed, complex examples of integration, and I was left thinking, that's phenomenal work, and how does anyone access that service? And so I think that's a reflection of the movement, that these are people who've been at this for a very long time, and it might be that they've done the analysis, and it might be that they're assuming it's red, but for people coming into this for the first time, that's got to be really critical. And so the lens that I'd love to see in the discussion as we're thinking about how are we engaging this in the Australian context, but Asia Pacific as well, is how are we connecting all of those issues about outcomes and evaluation and values of this work through the lens of the communities whose needs we're trying to meet. And doing that through co-production is part of it, having those voices at the table is part of it, but making sure that that's really central in the agenda that we're taking forward is something I'd be really keen to see.
Totally. So there's going to be a major focus of the Canadian conference, of course. And has been a major focus of previous comment. We're actually involved in a project called Integrated Community Care. And that's really fascinating because it's all about how we build the resilience of communities to be able to support better health and well-being for people through the partnerships you create, and that's been really fantastic project for us. So again, it's like, what are the things we're going to be able to take? But that's, that agenda is absolutely central to what makes an integrated care system operate effectively. I'm absolutely convinced of that. So yes, absolutely.
I would just like to comment too in relation to particularly the November Melbourne conference. Please do get in touch and say, what are the issues that you would like to see addressed? The reason I say that is it's very easy when you've been around a field for some time to say, I know what the key issues are, I know what the leading edge is, I know what people want. And a sort of individual arrogance comes in, and we design things like we've always designed them before. So I think, please do get in touch, send us an email, send us ideas, because we really do want to know what would be helpful. And we have responded in ways in the recent past. So for instance, we got a very strong message that people wanted to understand about how you did economic analysis of integrated care. So we brought someone over from Oxford to our accelerated development program. We linked them in with Liz Schroeder from Macquarie. And we tried to, as it were, respond to a particular request that was coming to us. So, we can't guarantee to answer everybody's problem or to deal with the full curriculum.
But
actually,
you're right, there is a
really
huge
keen
opportunity
to
over the next 2 weeks to help us shape the agenda for Melbourne. So just write to us. I'd like to see, and we'll see what we can get on. We need to talk. Listen, it's 4:30 and beyond, and there's the whole of San Sebastian out there, and it's not raining. So, listen, it's I've really enjoyed it. Thank you all for coming. I'm quite expecting such a big group, and thank you to the guys behind it. I didn't mention Richard and all of the team who've been here live streaming, or indeed the interpreters or anyone, so I apologise for that, but thanks to them, and particularly to help us set this thing up with as we went along. We hope to see you all in Melbourne, and by that time I hope actually to be there with my family. We'll see. But thank you very much. Great.